Welcome to Eye on the Cure, a podcast from the Foundation Fighting Blindness, providing science research, news, and insights about the world of vision and blinding diseases.
Welcome, everyone, to the Eye on the Cure podcast. I'm your host, Ben Shaberman, and I'd like to thank Amgen for sponsoring this episode. And for this episode, we'll be learning all about thyroid eye disease, also known as TED or TED, and we'll be learning from Dr. Prem Subramanian, who's with the University of Colorado Sue Anschutz Rogers Eye Center and School of Medicine. And at UC, Prem is the Clifford R. and Janice N. Merrill Endowed Chair in Ophthalmology, and he's a professor of ophthalmology, neurology, and neurosurgery, and he's also vice chair for academic affairs. So, Prem, welcome to Eye on the Cure. It's great to have you.
Happy to be here today with you, Ben.
So, I want to give our listeners a little more background on Prem before we begin our conversation. And he is a founding member of the medical staff of the Marcus Institute for Brain Health. He's also an active orbitocranial surgeon with a specific interest in tumors of the skull base. His current research is focused on finding more effective treatments for patients at risk for progressive thyroid eye disease. He's working on developing better treatments for vision problems in patients with increased intracranial pressure. And he's using vestibular and visual therapies to overcome visual and balance dysfunction after traumatic brain injury. And Prem received his medical degree with high honors and his PhD in molecular and human genetics from Baylor College of Medicine. So I want to talk more about this broad range of work you do. It's quite impressive. But first, Prem, tell us what inspired you to pursue clinical care and research in the neuro-ophthalmology space.
Thanks, Ben. Neuro-ophthalmology is the aspect of ophthalmology that deals with pretty much everything outside the eye. So you start with the optic nerve in the back of the eye, the orbital tissues, the muscles, the nerves that come to the muscles, and everything that comes from the brain to the eye and from the eye to the brain. So even though we are one of the tiniest subspecialties of ophthalmology, we cover an incredibly broad range of disease with overlap into ENT, into neurosurgery, neurology, of course, and then systemic medicine. So what inspired me is you go through medical school and you learn all these wonderful things about different systems in the body. And then you become an ophthalmologist and you're concentrating on vision, which is incredibly important, but it allows you to maintain that connection to the rest of medicine and to integrate some of the knowledge from fields outside of ophthalmology into the care of people with vision problems. And when I started this, which was a few years ago, there were not the number of potential treatments for people with neuro-ophthalmologic diseases, problems like optic neuritis or compressive optic neuropathy, or even disorders of the brain that affect visual functioning and visual processing. And we've made progress over the years, lots still to come, but it has opened up treatments for patients that really weren't available. So it just struck me as an area that was very ready for more research to be done, in addition to having people who provide the clinical care.
Right. And I'm familiar with neuro-ophthalmology, sort of at a basic level, but I love how you described it as having to do with vision outside of the eye. And I don't think we give enough appreciation to the brain for how important the brain is to vision, especially those of us in the retinal world. But is that challenging, really, to deal with the brain? There's a lot more going on than maybe a lot of us appreciate.
It's a challenge, and it's what draws those of us who do this into it, because it allows you, from a clinical perspective, to break things down sometimes into problems that are involved in vision processing itself, the afferent pathway, but then also eye movement control, which I think is less studied, especially by ophthalmologists. It's been the purview maybe of neurologists and ENTs, but ophthalmologists have a tremendous amount to contribute to the understanding of eye movement, the binocularity of vision, maintenance of fixation, and other disorders that really compromise vision, not because of, again, of the message getting back to the brain, but the control over the eye movement system. So yes, it is complex. It's, I think, fun to try to break down where the problem lies and then to be able to target a treatment or at least an explanation of what's going on with a given patient based on that localization of the particular problem.
So let's move into thyroid eye disease. And I know it's often misdiagnosed, it's underdiagnosed. Can you give us a basic definition of what it is and what it can do to the eye and vision?
At a very basic level, thyroid eye disease is defined as an autoimmune process where there are typically autoantibodies that recognize proteins that are within your thyroid gland, like the TSH receptor, the thyroid stimulating hormone receptor. And those same proteins, those antigens, are present on orbital tissues, things like extraocular muscles, fibroblasts within the orbit, fat cells. So again, at a basic level, your body is attacking those tissues within the orbit and leading to changes that can affect appearance as well as visual function. So the effects of thyroid eye disease can be felt anywhere from the front of the eye or even in front of the eye with the eyelids and their position and their thickness and swelling in the periorbital area. One of my colleagues likes to refer to this disease actually as thyroid face disease because it causes the mid-face, the cheeks, and other tissues to thicken. And it can affect the tear film, the corneal health. It can affect the intraocular pressure by congestion in the orbit. It doesn't really cause cataract. Maybe that's the one thing it doesn't do, but it can affect the posterior segment of the eye by affecting the health of the optic nerve, again, because of pressures that occur in the orbit from these tissue changes. So it pushes the eyeball forward. The characteristic thyroid stare that people think of with thyroid eye disease comes from that. But again, going back to the basic level of what defines thyroid eye disease, it all comes from that disease that's mediated by the immune system and then activation of various pathways within orbital cells that they then start to grow or put down substances in an abnormal way that leads to all of these other things happening.
Right. And not to minimize this broad range of symptoms and effects of thyroid eye disease, but it sounds to me like the impact on the optic nerve could be the most dangerous thing or the thing that's most dangerous to vision and leaves people susceptible to vision loss.
There are two ways in which thyroid eye disease can damage vision permanently. One is just as you said, the compression of the optic nerve, typically at the apex of the orbit. The orbit is shaped like an ice cream cone. You can think of the eyeball as the ice cream, and it narrows back to where the optic nerve exits the orbit. And if the muscles swell too much, there's not a lot of space because it's surrounded by bone. And so, yes, you can get optic nerve compression. But the other way that happens is if you push that ice cream too far out, it's not covered by the eyelids anymore. And so the cornea can become severely exposed. The eyelids don't close properly over it, and you can get a vision-threatening corneal ulcer. And that's the other way in which people can lose vision permanently from TED, and something that we don't necessarily think of as much outside of those of us who take care of a lot of TED patients.
Right, right. Interesting. Interesting. So how is thyroid eye disease diagnosed? Because the way you've described it, there could be a lot of different things going on, and I presume there's a spectrum of severity. What are some of the clues that somebody might consider for having thyroid eye disease?
There's indeed a spectrum, as you said. And so it's relatively straightforward when someone has a classic constellation of symptoms. If they come in with very swollen eyelids, if they have that thyroid stare, like I mentioned, if the surface of their eye is very red and inflamed, they may even develop something called chemosis, which is a bogginess to the conjunctiva, the clear layer in front of the sclera there. If they have limited eye movements, if they have known systemic thyroid disease, then the diagnosis generally is kind of straightforward. But there can be subtle manifestations. There have been studies that show that a significant percentage of patients who are diagnosed with dry eye from unclear causes, they actually have thyroid eye disease. And you can confirm that by looking at their systemic thyroid status and looking at antibody levels in the blood. So those are a couple of ways in which we try to make the diagnosis or help us in making the diagnosis of TED by getting this supporting information that goes along with what we see clinically with the patient sitting in front of us. Because at least 10%, maybe even more, of patients who develop TED may never have systemic thyroid abnormalities. Their thyroid gland may be functioning completely normally. And if you do tests of their hormone levels in their blood, that all looks normal. So you have to look a little deeper for things like antibodies. You also can do things like look at CT scans or MRI scans of the patient, looking at their orbital tissues, because TED causes characteristic changes, enlargement of the extraocular muscles in a particular pattern where some are more likely to be affected than others, and the tendons that attach the muscle to the eye are generally spared. So we can look for patterns of abnormalities in the orbit as well that help us to make the diagnosis. But the first step is the doctor has to be suspicious for it because of the fact that it can show up in so many different ways, and it can show up in someone who has absolutely no history of having had a thyroid problem.
Right, right. And I presume a lot of people see other doctors, whether they're ophthalmologists or maybe an endocrinologist or whatever, before they get to you. Is that often the case?
That is, they have usually seen, as you said, an optometrist or an ophthalmologist. They may be seeing an endocrinologist because they have known systemic thyroid disease. They may have started with their primary care doctor, and their primary care doctor sends them my way because they suspect it. So a lot of different doctors may be the ones who raise the suspicion for TED and suggest that the patient come to see someone who takes care of a lot of TED patients.
Right, right. And so I know that thyroid eye disease is more common in women, and it's also more common for people who have other autoimmune issues. Are there other risk factors? Are there any potential genetic risk factors?
There does seem to be some genetic risk factor in the sense that if your parents or other close relatives had autoimmune thyroid disease, then you may be more likely to develop Graves' disease, autoimmune hyperthyroidism. And since that is the primary risk factor for developing TED, then that follows from there. I think otherwise, though, there beyond what you mentioned of one autoimmune disease being a risk factor for another, smoking is a big, not a risk factor necessarily for TED, but a factor that predicts worse TED and more resistance to treatment of TED. And other systemic diseases don't necessarily have that same association with either risk for developing it or for progression over time. But interestingly, though, you mentioned that, and it is true that women are more likely to have TED than men, men tend to have worse TED than women do.
That's so interesting that it's less common in men, but men get more severe symptoms. Does anybody have any theories about why that happens?
No, one would think that it has something to do with other things like sex hormones or something else, or just the structure of the orbit, because it does differ between men and women on average. But I think it's still a mystery as to why men get worse disease. We joke that it's because men don't go to the doctor until their disease is worse, but studies have actually shown that's not true.
Interesting. Interesting. So, what are the range of current treatment approaches? Let's say for somebody who may present milder disease versus somebody who has a more significant case.
The approach is centered both on systemic things that you can change as well as treatment to affect the eye and orbit itself. So first, you want to establish if the person has good control of their thyroid status. Not because the thyroid hormone itself is what drives the thyroid eye disease, but if their systemic thyroid status is way out of whack, that's usually an indicator that their immune process is also revved up and leading to a worsening of the TED. So you want to try to get that under control. I mentioned smoking. If they smoke, you absolutely want to try to get them to stop smoking. And then there's some evidence that vitamin D levels may contribute, low vitamin D levels may contribute to a risk for having TED, or normal levels may be beneficial. I think it has some evidence, and it fits with the idea that there are many autoimmune diseases where vitamin D seems to be important. But then as far as treating the eye and the orbit, it does depend on what's bothering the patient. If it is milder in nature and the main things that bug them are grittiness of their eyes, irritation, maybe their eyelids are a little bit too open, you would start with conservative things like lubricant drops and having them elevate the head of their bed a little bit so that their eyes and face don't get quite as congested overnight. And you can often wait, because thyroid eye disease, if it starts out to be more mild like that, it may not progress to cause more symptoms. But if a person is having more symptoms and more manifestations of the disease, if they start getting the proptosis, the bulging of their eyes, if they start getting any double vision or difficulties with eye movement, or if it's just having more of an impact on their life, they're not going out because they can't face other people looking at them and seeing how their appearance has changed, then it becomes more appropriate to think about prescribed therapies. And there are a range of things that we can use medication-wise. There are steroids, there's an FDA-approved medication called teprotumumab, and then there are surgical things that we can do for patients. And we will intervene at different points in the disease depending on how far along the patient is, whether we think their disease is still changing, what other systemic diseases they might have that make them good or bad candidates for having any particular type of treatment. Sometimes we can even treat the orbits, the eye sockets, with a low dose of radiation to try to quiet down inflammation. So there are a number of different options that are available to us to try to help our patients with TED. And it's really important, I think, for doctors to assess how the disease is impacting our patients, because I think sometimes if we just look at the patient and measure stuff and then sit back and say, okay, I know what's going on with you, you don't necessarily know what's going on.
Right. It's a combination of a good clinical exam and the blood work, obviously, and maybe some history is part of that as well, I presume.
It is. History is really important. And I think, again, I have learned that listening to what my patient is saying that they have stopped doing because of their TED is often a pretty good gauge of how much of an impact that disease is having on them. And again, it may be different from what I see looking at the patient. Some patients come in with very severe bulging of their eyes and swelling around their eyes, and they tell me, doc, I'm doing fine. It doesn't really bother me. I work from home. It's no big deal. And other people, objectively, their disease may not look as severe, but it's had a tremendous impact on their life, maybe because they have double vision and now they can't drive, things like that.
Interesting. So everybody is unique, really, depending on how the condition is affecting their eyes and how it's impacting their life. If somebody's listening to our conversation and thinking, wow, maybe I have thyroid eye disease based on some of the symptoms you've mentioned, what do you think is a good first step? Who should they reach out to? What kind of doctor?
If someone thinks they have thyroid eye disease, and that's probably based on their symptoms or whether it's looking in the mirror and thinking that their appearance has changed, I think it's important to start with their primary care doctor and to make sure that they don't have, or to look for the likelihood that they do have some kind of systemic thyroid disorder. Then there are many things that can mimic thyroid eye disease. We didn't talk about that. And that's a critical aspect of making the diagnosis of TED is seeing someone who knows how to exclude other things. Because just because you have Graves' disease or Hashimoto thyroiditis, two of the most common autoimmune thyroid diseases, doesn't mean you're going to get thyroid eye disease, and it does not protect you from getting things other than thyroid eye disease. So what can mimic thyroid eye disease? You can get a condition called idiopathic orbital inflammatory disease, which is also an autoimmune process, causes swelling and pain and redness, but it appears a little bit differently, and it is treated by giving the patient steroids or sometimes what are called steroid sparing agents and getting that under control. And if you treat that patient like they have thyroid eye disease, they're not going to respond properly to the treatment that you give to them. There can even be tumors in the orbit that can grow. So, we think of thyroid eye disease as being something that affects both eyes, but a not insignificant number of patients, the thyroid eye disease will be extremely asymmetric or maybe only affect one eye, and the other eye may look completely normal. And so if you mistake that for thyroid eye disease, when in fact there's really a growth behind the eye that you need to address, that's important. There are a couple of other things that can do it, some vascular problems and things. So seeing someone who knows how to differentiate amongst these conditions would be hand in hand with going to see the primary care doctor to look into systemic problems. So who should be able to do this? Optometrist or ophthalmologist is absolutely the first person to start with. But if they are unsure of what's going on, or they think it's TED and they want to enlist someone to help with treatment, then they should send a person on to see a specialist in TED, and that's often a neuro-ophthalmologist or an oculoplastic surgeon.
It sounds like for many people, it will be a journey to getting a diagnosis. It's not a quick binary decision as to whether somebody has thyroid eye disease or not, that it may require a lot of different tests to understand exactly what's happening.
That is very true. And sometimes time is needed to convince us that it is actually thyroid eye disease, especially if it is subtle or it presents in a somewhat unusual way. If the person has double vision, but they don't have any bulging of the eyes, and the pattern of eye movement abnormality is different than what we typically see with thyroid eye disease, for example. Or the example I used at the beginning of someone who has dry eye, and dry eye is very common, but they may then later develop some signs like eyelid retraction or other things that lead to the diagnosis of TED. So you're right. It may be either because the signs and symptoms don't all develop at once, or because things can come and go as well. And so that can be confusing as well and can lead to a later recognition of the disease rather than figuring it out when the patient first shows up.
Right, right. And this discussion really demonstrates why it's an underdiagnosed condition. It's a challenging diagnosis because of the range of symptoms. So, to conclude, I wanted to get back to your work because you are doing some research to potentially develop better treatments for people with thyroid eye disease, or at least preventing progression. Can you talk about your current research for TED?
There are a few things that are going on. There are clinical trials that are being conducted to try to bring new treatment methods, whether it is a different way of attacking the thyroid eye disease, the autoimmune process, or whether it is showing how to modulate the disease at the tissue level and have a continuous reduction in that autoimmune process in the orbit. Those are different approaches that are being studied. And so our center, along with others, are working on some of these clinical trials. In addition, one of the things I'm really interested in is trying to determine what the best long-term strategy is for treating patients who have TED. We used to think that the majority of patients, their disease would be active for about 18 months or so and then burn itself out. And then we would do surgery and we would be done. But we're learning that many more patients than we thought are having flares of their disease later. So one thing that we are working on research-wise is there a sequence of treatments that we should be giving our patients with thyroid eye disease? You treat them first with one particular drug, then do you do surgery, and then do you treat them with another drug, or you treat them with two drugs in sequence and then do surgery if necessary? And how do you really make this a durable approach along with their endocrinologist, keeping their systemic disease under control to minimize the impact of these changes to them over the long term? So that's, I think, one of the particular areas that I am interested in is how do you fix double vision in people with thyroid eye disease? The ability to do that right now predictably is still not as good as we would like. And so that's a particular interest of mine, designing treatments that are particularly effective at getting rid of diplopia, because to me, that's one of the most disabling aspects of the disease.
So not only is the diagnostic journey challenging, but once somebody is diagnosed, the treatment journey can be challenging, as you're saying. And I appreciate that you seem to be drawn to these challenges as we were talking about your background. So thank you for the great work you're doing for people with thyroid eye disease and your clinical care and your research. And thank you today for giving us a great background on the condition and ways to diagnose it and address it. It's been really informative.
Well, you're welcome. It's been my real pleasure to speak with you today, and I hope that your listeners take away some good knowledge from this episode.
I'm sure they will. And to close out, I'd like to thank Amgen for sponsoring this episode. And thanks again, Prem. And thanks to our listeners for tuning in to Eye on the Cure. It's always great to have you tuned in.
This has been the Eye on the Cure podcast. To make an impact, donate now at fightingblindness.org.